this year, finally, biologicals arrive in allergy. We already had this 2 or 3 years ago, and they arrive more and more. We have phase 1, phase 2, phase 3 studies, and hopefully we will also be able to give this also to real patients outside of the studies, because the price, to my eyes, is a limiting thing that we can use it in everyday practice. Another highlight is that the tablet immunotherapy has now also gone to Birch. We will see how this really works, but the results seem to be promising of the phase 3 trial, and we will see how it works on the big rollout. And what is also interesting to me is adverse drug reactions have always been my personal hobby for many years. Without the market and no interest of anybody in this very difficult field, that it becomes more and more aware. We see that the symposia get more and more prominent. We have more and more workshops dealing with this difficult to treat problem, because there are easy things more or less easy things in allergology, like pollen allergy. It's very clear, the history is clear, we have clear diagnostic tools. We have therapy that works more or less. At least we reach good life quality most of the patients. But then we have this difficult topic of drug reactions. And I think we have increased a lot awareness over the years that history is mostly wrong. And I think this is one also of my personal highlights, that we now see that drug allergy is not only the topic of the freaks, of the allergy freaks, reserved to special meetings where we put them into a container, but it is really aware that it is a problem that allergology should be taken serious, although it's not an easy to solve problem in every single patient. I personally was most impressed by the session about the Dieselgate affair, because that's what you really expect about Munich. Munich has such a strong tradition in environmental issues, and now as Volkswagen is a German company, it was very nice to put this up. And I was not aware, it's really old data, that diesel particles, it's data of the 90s, but they really brought it again into awareness, because the data is so old that I was not aware, because it was before I entered into allergy research, and that it was already clear 25 years ago that diesel particles are a real strong driver of allergy. So this is really, although it's not very new, it was my personal highlight this session. I really appreciated this very popular topic, putting it into an allergy congress. I would really look for an easy to do in vitro test system for drug reactions. And although there's so many humming and buzzing about the basophil activation test, I don't think that this really is a resolution for many of the patients, because we have still no good in vitro test systems for the cutaneous drug reactions, so the type 4 allergy, where we still have to rely on the patch test and the LTT, which is the lymphocyte transformation test, which is also a very old technique that comes a little bit into fashion again, but the results are not very robust or reliable, so they are good for research but do not really help a lot in everyday life. So personally, these were the techniques that I would be looking for, but at the moment I don't find any progress in this field. So we still have to use provocation tests in many of the patients, and provocation test is only the last resort. When you have no other way of coming to a diagnosis, you have to do a provocation test. Personally, I think that we have long been overlooking the atopic eczema, because this is really a disease with a very, very high impact on the life quality on the patient. But it has been less attractive as there were no treatment options. And so maybe the new biologicals will also bring more attention to this neglected disease. As I'm a dermatologist and I see 1/3 of my patients are children, but 2/3 are adults. And especially with the atopic adults, it's really a problem that they just don't want to use the cream anymore. They just don't want to use the corticosteroids anymore. They are using them now for 30 years. And they know that they help, but only for some time, and then the eczema will reoccur. So therefore, dupilumab and also other antibodies might really bring into awareness the patients, make them also bring back to the physicians, as also the physicians have lost the patients as you had nothing new to offer. And so personally, I think that this has been really a development in the last year, the last 2 to 3 years, that is promising. And although so well known, atopic eczema in adults is not a very much liked disease also by dermatologists, because these are difficult to treat patients. Well, I'm the old school type and I really miss my paper program. And I've talked to a lot of people of my age, so 45 plus, who cannot really find themselves through the app. So at the moment, yes, this is hard to find. I think that I really oversee many sessions that just get lost because I didn't look at them in the app. And what I really like to do in former times, I just flipped to the program and had nothing special in mind, and then just by chance some session came up and I went into a session that I would have never been interested in. And in most of the many years, these were the most rewarding sessions, as I've learned something completely new. And I think these surprises are hard to find now. And the second thing is that I think by using the app, we have a situation that the posters lose attractiveness. As many people just used to walk through the poster sessions when they were offline already. So when there were no presenters around, but you had some break, had a coffee, and didn't want to go into the session because it was already half an hour, then you went to the posters and went through the posters. And now this is not possible anymore, as you just have to select at the screens a specific poster. You're not just walking by. So, but maybe I'm already the old school that is only not willing to change to the modern system. I would really recommend, if this is your first time, go to the plenary sessions. We have already a lot of different plenary sessions. You may even choose between different topics, because they are mostly at the introductory level and try to cover the broad range. Don't be too focused. This is a big meeting. This gives you really the opportunity to see the whole variety of allergology. If you're interested in a special topic that your research is connected to, then you have the focused meeting. And usually the focused meetings are the ones where you get the new data, and here it's rather be broad. Use the opportunity to screen through everything. Well, to be honest, the big congresses are not the ones where you get a lot of clinical information. The big congresses are the ones where you meet the colleagues. I think this is the main role, is the networking, because you have so many of the colleagues at the same place and you can just meet them. That's my personal reason for going to the big meetings. So personally, the clinical daily work here in EAACI is not so in focus. If you really want to know how to patch test, then go to a patch test course. If you really want to know on how to do a lung function, then do a course. But I think this is not the role, the most important role of a big meeting, to do clinical education. I mean, I've been a senior consultant now for 15 years, over 15 years, and so most of the teaching has to belong to the hospital. And this can just give you some additional things, or you can do courses outside of your specialty. That was what I was always interested in. As a dermatologist, I did a bronchoscopy course during one former EAACI meeting. So always look a little bit further from your own specialty. Personally, I would change to a system that already existed during the EAACI in Vienna, to really have the plenary as the plenary that is not divided by other plenaries. Because this is the role of the plenary session, that you really think that this is the topic that the organizers believe is mostly important. And the same as me, you have no chance. There is no track of a single plenary. We have the other organization. We have the same plenaries at the same time, and then we have, for example, the abstract time. So this is the thing that I would change. I would really rather focus on one or maybe two plenary sessions, and then divide by the rest. And the other thing, I would try to give the abstracts, the real research that is presented by many of the attendees, a bigger role that it already had in the past. Personally, I think that we, as a dermatologist, I always saw it that we already had in dermatology a very small role for presenting your own data. And I always liked this about the allergy field, that in allergy this had a broader opportunity to be presented on poster sessions that were well attended. But nowadays we put the posters in a very crowded space where there's a lot of noise, a lot of people among very close screens. You can hardly get a word because it's so loud. I don't really think that that the people who worked 1, 2, 3 years to produce this data deserve this, to have to present this in this way. So I would rather give them more space, value space, big rooms, and have, if we present on screens, then we have to use big screens and more screens. We have just, I think, I counted something like 20 screens, which is really not much for more than 1,000 posters. Well, the main take-home message is, as I said before, we have finally the era of the biologics has also entered allergology. Although allergology was one of the first disciplines with an own biologic, the omalizumab, the anti-IgE antibody, it was one of the first biologics around, but it was very, very unique. It remained alone for long years of time. So this is the one thing that we finally get more treatment options for atopic eczema. The second thing is that we have the development of more sublingual immunotherapy. But as I'm also working as a practicing allergologist who sees a lot of patients, I also have the problem that we are only focusing on the major allergens. So everybody is producing diagnostic tools and a lot of research, and also a lot of medication for just house dust mite, grass pollen allergy, maybe ragweed, and maybe also in Central to Northern Europe, birch pollen. But we have many more other inhalant allergens around. And currently we are losing them. And I really laugh at the term personalized medicine, because allergy, it has always been personalized medicine from the very beginning, because allergy always meant that this was not an allergic patient, this was a patient who was sensitized to a special allergen. And then you had to choose your treatment options according to the sensitization pattern of the patient. And we really have to be aware that we are at the moment losing this, as we are only focusing on the major allergens, and the problem with the minor allergens are that they are usually local allergens. We have local allergens that are only important in some regions of this planet, and therefore we don't have the big market for these products. And currently we are losing them. We're currently losing a lot of skin prick test substances. We're currently all the companies are developing immunotherapies for the same allergens. I personally, for example, see a lot of patients sensitized to alternaria, to mugwort, to ash tree pollen, to saltworm. These are all allergens, and these make up to 30% of my patients. And I have no treatment. All I can do in them is to use an antihistamine or to use a very old immunotherapy where I don't know whether this immunotherapy is really of the high quality that we usually want to give into patients nowadays. So I don't see an end of this discouraging development also at this EAACI. Well, currently we have an overregulation in allergy. The overregulation means that especially prick test substances on the one way become expensive and on the other way are not produced because there is no market for this, because most of the health authorities are not really willing to buy to pay a high price. It was always these diagnostic tools have been produced by the allergen manufacturers as a side product of the immunotherapies, but now as the regulators are asking for higher and higher standards of these extracts, which is a good thing on the one side. On the other side, it means that if you put on all your resources as a manufacturer into just developing the 3 or 4 major allergens that you can sell on the wide range, you will just close down the facilities for producing all the other diagnostic tools. And this is what we have been facing as practicing allergologists for many years now, that if you look into a catalog of diagnostic products that has been produced 10 years ago, then you will find at least 3 or 4 times more extracts than are available nowadays. So this is the big challenge. How can we keep the prick test upright? It's nice to have good in vitro tools. We know the limitations of the in vitro tools. I'm using a lot of component resolved diagnostics also in everyday practice, but I also am very aware of that component resolved diagnostics has its limitations, and it makes only sense in combination with an easy to use tool, and this is the skin test, and this really is the big powerful tool of the allergologist, is the skin test, because after 15 to 20 minutes you can discuss with the patient the result. You don't have to wait for 2 or 3 weeks until the results of the in vitro test are finished. You can go right away. The patient enters the room, you make the skin test, and you have a solution for the problem of the patients after 30 minutes in most of the cases. And for the difficult cases, then it's a good thing that we have additional tools. But for the easy cases, we have skin tests, but we need to rely on the extracts also for rare allergens. And this is the big challenge that I see nowadays for our specialty.